the climate of, gosh, what was I talking about? Xenophobia, dislike of the other, and the kinds of ways in which that makes an opening for incorrect behaviors and wrong behaviors and evil and hateful behaviors to enter into the community has been once again brought to our attention by affairs on the other side of the country. So let's all be mindful of that so that we don't have to be like that.
Maybe you should say, maybe not everybody knows.
Oh, you want to say?
No, you should.
Somebody who was very anti-Semitic went into a synagogue in Pittsburgh on Shabbat and murdered 11 people. And a bunch of other people were wounded, and he was wounded. And it's unclear, other than just hatred, what his motivations were. So that just happened this morning. And you know, MAPS, we've had these big psychedelic science conferences, but we're not ready to do another one, so we've been in sort of mini conferences, and our last one was in Pittsburgh. And so we worked with some of those people from the temple. And,
So we've been talking a little bit here about xenophobia, and hopefully we'll figure out a way to overcome that as a nation and a people. But I do get to introduce Rick Doblin, and I was going to try to give him a funny introduction, but I almost can't make it funnier than the one he wrote, so I'm just going to read it. Rick Doblin is the founder and executive director of the Multidisciplinary Association for Psychedelic Studies. He received his doctorate in public policy from the Kennedy School, where he wrote his dissertation on the regulation of the medical uses of psychedelics and marijuana, and his master's thesis on a survey of oncologists about smoked marijuana versus the oral THC pill in nausea control for cancer patients. His undergraduate thesis at the New College of Florida was a 25-year follow-up of the classic Good Friday experiment, which evaluated the potential of psychedelic drugs to catalyze religious experiences. He also conducted a 34-year follow-up study of Tim Leary's Concord prison experiment. Rick studied with Dr. Stan Grof and was among the first to be certified as a holotropic breathwork practitioner. His professional goal is to help develop legal context for the beneficial uses of psychedelics and marijuana, primarily as prescription medicines, but also for personal growth for otherwise healthy people, and eventually to become a legally licensed psychedelic therapist. He founded MAPS in 1986 and currently resides in Boston with his wife and empty rooms from 3 children who are all in college. Now what could be better than that? And I think I've been at this for a long time. Thank you very much for coming, Rick, and welcome. Oh yes, that's right. Rick prefers that if there are questions that members of the audience want to ask about his presentation, that you would feel free to raise your hand, and I will bring you a microphone so that you can ask them during the presentation rather than holding them to the end.
yeah, that'll be more fun. And what could be better than having 3 empty rooms for kids in college is actually having some of them graduate. So 2 of them have graduated. One is working, and the other one is in the midst of an existential crisis about what to do next, and the one is still in college.
I have a drug for that.
I've suggested it. And I think it's worked, actually. But, all right, so what I'm going to be sharing with you today is sort of a project that really was inspired in my life by Stan Grof. And it's about trying to mainstream psychedelics and mainstream the states of consciousness that psychedelics can produce, and do this initially strategically for medicine, but also for personal growth. And so what that means is post-prohibition world, we need to go beyond prohibition and make it so that people don't have to have access only through doctors or only through religions. I'm personally allergic to religion in a lot of ways. And but I think that there's a lot of value in certain kind of cultural group context and religious context, and there's a lot of value in therapy, extremely a lot of value, but I think that's a fundamental human right to explore your consciousness. And so that's kind of the big framework I wanted to start just by thanking Janice Phelps and all the rest of the people here at CIS for creating the opening for talking in an academic setting about psychedelics, and for their program, their psychedelic therapies and research program that's trying to help train the next generation of psychedelic researchers and therapists. And more it's going to be about therapists rather than researchers, because as we're doing the research, we're going to be able to demonstrate safety and efficacy, and hopefully we're predicting 2021, get MDMA approved as a medicine, and others are working with psilocybin to do the same. Ketamine clinics are happening all over the place. So I'd like to really just acknowledge the major role that CIS is playing in trying to bring this to the fore.
Very good.
Very good. I also want to acknowledge Stan Groff and Brigitte. So this was taken a few hours ago. So I'm very interested in keeping things up to date. So I just was visiting with them, and basically I took a bunch of LSD when I was 18 years old, was very confused about it. I went to the guidance counselor at my college, and I said, help me with my LSD trips. And this was 1972. And this guidance counselor was pretty sharp, and he said, it's legitimate what you're trying to do. We got to work out these issues. And he gave me a manuscript copy of Realms of the Human Unconscious before it was even published. And reading that book solved my existential crisis, basically. And I said, this is what I want to do, because it was a combination of spirituality without dogma, of science with values, and it was focused on healing, so that it wasn't philosophy, endless philosophy, speculating. It was this reality testing of, are these ideas of the unconscious that we're learning from LSD, are they something that can practically be used to heal people? And it was done in a research setting. So it sort of combined everything that I felt that we needed, this access to this mystical sense of connection, and reading that book sort of put it all together. And so in 1972, I wrote a letter to Stan Groff. And to my astonishment, he wrote me back. And that led for me to take a workshop with him when he was just married to Joan Halifax. I was kind of a shy 18-year-old, and we didn't see much of them outside of the seminar, and the rumor was they were practicing tantric meditation. But in any case, I was very inspired by Stan at an early age, and so now, all these years later, it was just really a pleasure to be there together with Stan. So I want to acknowledge his role in really pioneering this work, and not only that, but when the crackdown happened and a lot of people moved into non-drug approaches, Stan did the same, in that he developed holotropic breathwork, a way to use hyperventilation to create non-ordinary states of consciousness, but he always kept focused on psychedelics as well. He didn't sort of deny that they were valuable. He didn't say, oh, you've done psychedelics, now let's move on to the next step. We don't need them anymore. He sort of carried the flag for psychedelics, and has been a personal mentor of mine. And so what I'm going to talk to you about is a lot of research, a lot of things, but I just want to give you a brief sense of how many people have come together to create this. We have several people from MAPS right here, Marita and Jade. But MAPS has now grown. For the first 7 years, I started MAPS in '86. From '86 to '93, I was the only employee. There was only one person, and now we're over 45 people, and we're at this growth stage. So this is just a picture of some of the MAPS staff. We also have a separate company that I'll explain a little bit more about, called the MAPS Public Benefit Corporation, which does the research, will train the therapists, and will also sell MDMA by prescription, and then channel the resources back to further research. So this is part of our benefit corp. And then we also have principal investigators. We've trained over 80 therapists, and these are just our US sites. You can see we have a training team, but we only have 4 lead trainers right now. So the key limitation as we go forward is, how do we scale up the training program? And that's why I so appreciate what CIS is doing here with their training program. And we've trained a whole bunch of therapists. This is just over the last few years. This is just to give you a sense of how many people we've trained. And this was just earlier this month in Europe. So we're also both trying to make MDMA into medicine in the United States, and we're also moving through the European Medicines Agency. And since this is a place where training has, a therapist has taken place, I just want to say that we have developed what's called a manualized therapy. So when you want to move something through the FDA, you standardize the drug, obviously, but you also, in our case, because it's drug-assisted psychotherapy, it's not MDMA as the treatment, it's MDMA-assisted psychotherapy. So you have to standardize the therapy. And to do that, this is really based on a lot of the work that Stan and others did with LSD research, but we have modified it for MDMA for post-traumatic stress disorder, and this is the manual that describes it. And in addition to this manual, we've developed what are called adherence criteria that we've trained people to watch videotapes of the therapy sessions, and then they can actually give feedback to the therapist on how much they're adhering to the method. And it's not that we think that this is the best method of the world, or that other people couldn't use other methods and get people better as well, but it's just this is the way we think to optimize it. And so this is what we're teaching. Once it's approved as a medicine, everybody's going to have training in this method, but then they can innovate and do whatever they want. They're not going to be constrained to just doing this method. And so our training program has multiple parts. It starts with an online course, which orients people to MDMA, to PTSD, to the treatment manual, things like that. And then we have part B, which is a week-long in-person training, which the photographs that I showed you were from that. And that's mostly going over the manual, but watching videotapes of actual therapy sessions, and then talking about why did the therapist say this instead of that, how come, you know, this approach. So it's sort of to get a sense of really the range of experiences that people can have when they're working through PTSD. And that's very, very effective. We also have this part C, this experiential elective, where we can give MDMA to therapists as part of their training. We have a special protocol. This is where we really saw that the FDA was dealing with us in good faith, because we went to them and we said, there's a small group of people that we're working with. They've had a lot of experience with MDMA. I mean, we didn't quite say it this way, but a lot of it was underground and some of it's above ground. But as we reach out to try to train new people, we want to be able to give them MDMA, because you wouldn't go to a yoga teacher who never did yoga. You wouldn't go to a meditation teacher who never did meditation. Now, you know, people will go to a psychiatrist and get electroconvulsive therapy, and we don't expect the psychiatrist to be shocking themselves. So it's different, but we believe that therapists and psychiatrists would be more effective if they've done the drug than if they haven't done the drug. And so we proposed this to the FDA, and the FDA said, we can't give you permission just to give MDMA to therapists, but if you wrap it in a study, we don't care what you study, we'll let you do it. So we developed a protocol, and we've taken over 60 people from all over the world and given them MDMA. But this is really important, is that we don't want to require it. We don't think that people should be required to do a drug, and we think it should be optional. And we want to welcome skeptics. We want to welcome people into our training who, for whatever reasons, might not be willing to take MDMA, and that's fine. We wouldn't be as enthused about hiring them to work on phase 3 or anything if they hadn't done MDMA, but at the same time, we want to really welcome people into the program, whether they want to do MDMA or not, and if not, they can do something other, like holotropic breath work, or do some other kind of Hakomi training or something. And then we also have part D, which is role play with therapy, so that people will do role play, videotape it, and then our training team will watch the videotapes. And then we also have the final part, which is really the way you train therapists is you have them work with patients under supervision, and they get feedback, and that's the best way to do it. But with a Schedule I drug like MDMA, we can't do that other than inside a protocol. So we're limited by how we can, now we do have, I'll tell you more about it later, but we have the Zendo Project, which does psychedelic harm reduction at Burning Man and elsewhere. So people volunteer for that. We do give some training there, and they actually work with loads of people that have done all different drugs. They don't know which drugs they've done a lot of times. We don't know. but it's another way to get training. But really, the best way is to work with patients. So we're requiring everybody to work with one PTSD patient in the same protocol that we use for phase 3, and they'll do under supervision, and that's the final part of the training. Then they're going to have a little certificate and to show that they've completed the training, and this is your normal certificate, but this is the one if you've done MDMA. We think patients have the right to know if their therapists have done MDMA. And, and there'll be similar things like this for psilocybin. Now, just to give you a brief sense of how amazing the cultural transformation is that we've been going through, and it's been accelerating recently. So I'm just going to give you now a brief tour of just what I've been doing in the last 2 months, just to give you a sense of different kind of communities I've been speaking to. So this was at Burning Man. This was the opening ceremony at our village here. But what we do is we do psychedelic harm reduction at Burning Man. And also it's one of our major fundraising tools is to meeting people at Burning Man. We just got someone who has pledged $750,000 a year for 5 years for operational expenses. And the only time I've ever met them was one time at Burning Man. And there's other stories like that as well. So I was just at Burning Man. This was the original Zendo from 2006 when we, this is Paul Disco, who's a famous Zen architect of Zendos, and this was Vanya Palmers, who donated it to MAPS, brought it from Switzerland, and he brought it along with a bunch of Zen meditators. And there was always somebody meditating for the whole week, and they were interested in combining meditation, dance, and MDMA. So it's the latest development for Zen is moving forward in this way. And there's more and more research now being done with lifelong Zen meditators and psilocybin as well. This is just to show you our training program for the people working at Zendo at Burning Man. We had about 900 people volunteer. We picked around 220 or so of them, and we had the training in our village. And this is really to both help train people, but also to try to calm society down about people having difficult psychedelic experiences. We can process them. We can help them learn from them. It's not like it's a dead end. It's not like they have to go and get tranquilized or arrested or anything like that. So the Zendo Project is really important. This was several years ago where we got our own flag. We were finally able, so the Burning Man organization is now comfortable with what we're doing, as is the Bureau of Land Management, the BLM police. So several years ago, Sarah Gale, who's in charge of the Zendo Project, gave a talk to the police at Burning Man about how to de-escalate psychedelic challenging experiences. And so now we're pretty well integrated with the police as well. So from Burning Man, I went to the opposite, to New York, and I spoke at the Oslo Freedom Forum, which is run by the Human Rights Foundation, and this is for human rights activists from all over the world. And the reason that I was there was to give them hope about the treatment of trauma, the treatment of PTSD, because a lot of the people who work for human rights are traumatized themselves. And so this was really the purpose why I was invited, both to talk about that and to talk to different individuals about therapy options that they could have. But it was at the Kennedy Center in New York. Then this is a picture of Amy Emerson and her translator. She was in China recently, so a MAPS donor is interested in having us bring MDMA to China. And what he said is that when we had the psychedelic revolution in the 60s, China had the Cultural Revolution. And his parents and their whole generation is traumatized from that. And so he wants to try to bring MDMA to China. And so Amy was sort of the advanced scout for one meeting, and then I went just at the end of September. And this is a picture of me. This was the conference of the Chinese Medical Association and the Chinese Psychiatric Association at Shenyang. And so we were presenting, and we was myself and also Moshe Kotler, who was the principal investigator of the Israeli study, and he used to be the former chief psychiatrist of the Israeli Defense Forces. And so he was there to give credibility, which he did. And then this is, again, another picture from that. So it was kind of surprising to be in China. When I was at the Kennedy School getting my master's degree, it was during Tiananmen Square. And so I organized through the student government at the Kennedy School, with student governments all over the world, an international day of fasting for freedom and human rights in China and Tibet. And we actually got a bill commemorating that day through Congress. And one of the people that was speaking also at the Human Rights Forum was a demonstrator student from Tiananmen Square who got his legs crushed from a tank. And so being aware of the authoritarian nature of the Chinese government and then actually being there in China was a little bit shocking, and it was much more of a warm reception than I could have anticipated. So from China, then I went to Europe, to the European training, where we're training 60 people from 14 different countries, mostly through Europe, but also we have people from Israel, from Afghanistan, from Australia, so we're really trying to globalize this, and the training went great. But as soon as I got back, I was only home for a few days, and I had, for me, what was the most astonishing experience in the last couple of months, and I spoke here at the International Association of Chiefs of Police. And it was in Orlando, and it was about MDMA therapy for police officers with trauma. Now, we have a senior retired DEA official who's working with us now, and the reason is because his son went into the Army and has PTSD and uses marijuana for PTSD. So that changed the attitude of his father. And his father is now working with us and arranged for this talk here. So I've long felt that the police are the predators and I'm the prey. And you know, I've identified myself as counterculture drug-using criminal from trying to go legit. And so to be surrounded by thousands and thousands of police, what was really surprising was the exhibit hall, where all the new technologies for police, all the new body armors, all the new ways to disable people through sound, all the new police cars you could buy, just all the police technology was kind of surprising. But what maybe wasn't surprising is that President Trump decided that he wanted to speak here as well. And so he decided to come at the very last minute, and he was scheduled right at the same time our talk was scheduled. So he was not able to come to our talk, which would have been very good for him if he could have. But we still got around 25 people, and one of the people that was there was a police psychologist who now wants to go through our training program. So it's really exciting. And then they rented out the entire Universal Studios in Florida for a police party that we went to. It was kind of fun. But when I went to college in Sarasota, Florida, it was a rite of passage. Everybody had to take LSD and go to Disney World at some point. And so I kept thinking, this party would be a lot more fun. But I think, no, I'm not going to do it. All right, so then from there, I went to Harvard. This is now a conference that took place at the Broad Institute. So Eli Broad is a philanthropist from LA. He gave over $1.5 billion to this. The largest grant that's ever been made to mental health research was the Stanley Foundation that gave them $650 million. So they do genetic research for all kinds of diseases. Now they're also looking at mental illnesses, and they've got like 600-700 scientists between Harvard and MIT. And so what I really, really like about this is that this talk was sponsored by the Broad Institute, the Brain Science Institute at Harvard, Harvard Medical School, MAPS. And this was Stan Groff's holotropic breathwork. So this was sort of bringing psychedelics back to Harvard. And let's see. And it went great. And so all these other speakers, Robin Card-Harris was there on video, but this was Michael Pollan was also one of the speakers. And he's made such a big impact through changing your mind. But from that, I went to this. This is a place called Agapolis. This is not that far from San Jose, and this is one of the early Facebook people. And this was a conference on, Reese, you were there as well. This was a conference on different philanthropies. Oops. Let's see. So this was cryptocurrency donors meeting various philanthropies. 10 charities were invited to give presentations. And so it was just a bird's eye view of Silicon Valley. So from there, I went to Esalen. And Esalen was devoted to Burning Man. So Burning Man took over the entire Esalen, and they were having a convening at Burning Man. And because of our Zendo project, I was invited, and that's Marion Goodell, who's the founding, or the CEO of Burning Man. And this was incredible because this is 1982 at Esalen, that's me. This is when I first learned about MDMA. And so I won't go into it much now, but I had raised a Timberwolf, and so I was kind of in my wild stage, and this was my first sort of coming up from the wild stage to study back in college. I started back in college in '82, and this is a picture at Esalen. And this is me when I learned, so this is what you mean when I say I'm trying to go legit. This is sort of like coming from the wild outside. And so just along of these themes about going legit, what's happening in 2 weeks, so I'll go a little bit further, is I'm going to Washington, D.C. And so we have brought Burning Man to Washington, D.C. And we have an event on the Washington, D.C. Mall called Catharsis. Daryl Duane and Natalie Ginsburg from our staff and the D.C. burner community, and Dr. Browners and others, we organized this. This is the first fire on the Washington Mall since World War II. And we were burning up a jail cell. This was the temple that when it started burning, it turned into a jail cell, and then the jail cell burned up. This is the second year. This was another temple. They didn't let us burn this, unfortunately. But we were able to bring our art car. Dave Browners brought the art car. So, and this is my favorite picture of them all. But the idea here is that we really need to bring ourselves together. That's what we mean by mainstreaming psychedelics. We don't want to be outsiders, and we want to be fully accepted. This was Sunrise. This was right after Trump got elected. So this is where some of us kind of got our fighting spirit back, realized we're still part of America too. And so on the theme of bringing our Burning Man self, our psychedelic self to the culture, there's also the theme of bringing our political self to Burning Man. So that's a picture of that. So that's just the last 2 weeks and coming right up. So things have been just incredible, from police to Harvard to all over the place. So culture is changing in a very rapid way. Briefly, why? Why do we need to do this? According to Einstein, it has become appallingly obvious that our technology has exceeded our humanity. What that means is that we can destroy the world, and we are destroying the world, and we have mass extinction and global warming, and so, but we don't have the emotional, spiritual capacities to deal with that. And so when I read this a long time ago, that's why I thought we need to focus on developing our humanity, and that leads directly to psychedelics. UNESCO Charter: since wars begin in the minds of men, and it is in the minds of men that the defenses of peace must be constructed. So again, we're focusing on our way of thinking as what really needs to evolve for us to pass through these terrible times that we're in now. And this all was confirmed by Robert Mueller, this theory of change, that the mystical experience of connection is the antidote, the sense of being part of everything together, that, you know, the murders that took place in the synagogue this morning, how do you dehumanize others? How do you consider them less than or other if we're all in it together? And it's one thing to say it, but it's another thing to feel it. Rita Marley, Bob Marley's wife, had an album called Who Feels It Knows It. So Robert Mueller wrote this in '83, this book about how really what we need is global spirituality. We need people to have this more powerful sense of how we're all in it together, and that's the antidote to fundamentalism. And his book didn't say anything about psychedelics, but this was his theory. So I wrote him a letter, the same way that I wrote Stan Grof a letter, and again, to my surprise, he wrote me back. And I said, we need psychedelic research. You say it's so important, would you help bring back psychedelic research? And he said, yes, he would help. And eventually he did, and he also gave me a bunch of mystics to communicate with. And of course, I assumed he meant send him MDMA, which I then did, and then they would report back to him. Brother David Steindl-Rast, Rabbi Zalman Schachter, a whole series of Wayne Teasdale, who was with the Parliament of the World Religions. And so anyway, this sort of confirms the theory of change. That's why I think it's so important that we mainstream psychedelics, not just for medicine, not just for religion, but for everybody, so that we can have loads of people really knowing that we're all in it together. Edgar Mitchell, the astronaut, said, when we see our fundamental unity with the processes of nature and the functioning of the universe, as I so vividly saw it from the Apollo spacecraft, the old ways of thinking and behaving will disappear. And that is very true, that, but it's very expensive to send everybody up in space. So psychedelics are the efficient, cheaper alternative to this theory of change. And then we talked about my work as an undergraduate doing a 25-year follow-up to the Good Friday experiment that Leary and Walter Pankey did at Harvard. And so this is what I learned from talking to the people that had the psilocybin experience, that this mystical experience motivated them to move towards social change. They increased their acceptance of other religions and beliefs, they deepened their equanimity in the face of difficult life crises, they reduced their fear of dying, and they felt greater solidarity and identification with genders. They were all men, foreign peoples, minorities, and nature. So this really, for me, is the key to the 1960s. When you hear about the backlash against the 60s, most of the time you'll hear about it as a bunch of people unprepared, took LSD and other drugs, had emotional breakdowns, jumped out of windows thinking they could fly, that all of these things were because there was difficult experiences that people had with psychedelics. And that's why there had to be a crackdown to stop drug abuse. But really this points to a different factor, which is that psychedelics gone right inspires people to challenge the status quo when the status quo is discriminatory or waging war in Vietnam or destroying the environment. So really it was the challenge of people motivated by psychedelics challenging the status quo that really brought the backlash to take place. But again, this sort of confirms the theory of change. And another reason that we need to do this is healing PTSD and multi-generational trauma. This is Richard Rockefeller on the left, Larry Brilliant on the right. And this was 5 years ago almost. Not too long after that, Richard died in a plane crash. But he was my main thought partner for quite a few years. And we have these conflicts that go down generation to generation, hundreds, sometimes thousands of years, and it gets passed on in an epigenetic way, meaning the anxieties of the mother, they don't actually change the genes, but they change which genes get turned on or off. And so what we learned is now that we can interrupt multi-generational trauma in one generation, in one MDMA session sometimes, or one psychedelic session. So really, we need the sense of connection, but we also need to overcome all the trauma that people have got from all the fights for thousands of years. And so this is another reason to mainstream psychedelics. These are neuroscientists at Stanford said the world's populations need more compassion and empathy for one another. The study of MDMA provides one small but potentially important step towards reaching that goal. So now this was a call to the laboratory for all the world's neuroscientists to try to figure out, how does MDMA actually work? How do we feel more connection and more compassion and more empathy? Because that's what the world needs more of. And then the final step really of this theory of change is that legalization follows medicalization. So this is a chart of the American voters' attitudes towards legalizing marijuana from 1969 to 2017. So almost 50 years. And what you can see here is that this is the rise of this is the 60s, this is into the 70s, this is where people were thinking, oh yeah, marijuana is going to be legal right around the corner. And that's the way it seemed. But then there started to be a backlash right there from the parents groups. Nancy Reagan and Ronald Reagan got elected in 1980 with the Just Say No movement. And then there was this long period of basically nothing changing. And then finally what changed right around here, 1996, is California. You guys here in California passed the Prop 215, which legalized medical use of marijuana, and also in Arizona. And so what we see is this gradual climb towards, now this is not about medical marijuana, this is about legalization of marijuana. So medicalization is the needed precursor for legalization. And in fact, the people at the Marijuana Policy Project and the Drug Policy Alliance who are working on reforming drug laws, what they've said is that attitudes towards legalization of marijuana grow more from medical marijuana than from marijuana decrim. And you would think that decrim, since you're talking about actually penalties for illegal use, that you get decrim, then people more want to get legalization. But that's not the case. It's because medicalization provides stories of people that have healed from marijuana and help them with different things. And you see dispensaries that are not surrounded by people with machine guns, and it's you see a new way of handling drugs in our society from medicalization. So I think that really the medicalization of psychedelics is going to be necessary for at least a decade or more before we get to the legalization. So I'm currently projecting 2035 for the legalization of psychedelics, 2021 for medicalization, and then a decade and a half of rolling out psychedelic clinics. So everything is going really pretty well as far as psychedelics go. There's no regulatory obstacles. We've been able to raise the funding that we need for FDA phase 3. But the one area I'll just say, and this is the only time I'm really going to talk more about marijuana, is there's a study that we've got going for marijuana for post-traumatic stress disorder in veterans. And it's 4 different kinds of marijuana. It's taking place in Phoenix, Arizona with Dr. Sue Sisley. It took us 7 years to get approval for starting this study. It was rejected multiple times. NIDA refused, the National Institute on Drug Abuse refused to provide us with the marijuana a couple times. It's testing high THC, low CBD versus low THC, high CBD, high THC. Now, this is from the government. 9% is not particularly high THC, but this is the best you can get from the government monopoly. This was funded by $2.1 million from the state of Colorado for marijuana taxes. But the really next step that we need to make marijuana into a medicine, the same way it's happening with psilocybin and MDMA, is we need our own independent source of supply. You need a drug that could be medicalized. There's a monopoly that's been involved in the United States since 1968 on the production of federally legal marijuana. And that's run by the National Institute on Drug Abuse. It's produced at the University of Mississippi. And 2 years ago, finally, we managed to get the DEA to say that they would end the monopoly. And they published a notice in the Federal Register in August of 2016. And then shortly after that, Trump got elected and Sessions got appointed Attorney General. So this was the former DEA administrator saying that the DEA has yet to approve a single license application, and now acting DEA Administrator Chuck Rosenberg is set to resign over differences with the Justice Department. One of those differences, the Justice Department's refusal to let the DEA grant any licenses to grow research marijuana. So you can see this was over a year ago that they said this. So we've sued the DEA. This was back in 2005. We had a protest on the lawn of the DEA. This was in the courtroom. The courtroom was inside the headquarters of the DEA. I'm proud to say that they let us in and they let us out. So we're about to sue again to try to force the DEA and Attorney General Sessions. So this is the main way that science is being blocked by the drug war. Not so much with psychedelics, where you would think maybe that would be more, but it's with marijuana. And I think that's because more people use marijuana, more people could change their minds about drugs. And so the clampdown is still there on marijuana. And so we're working on this to try to firmly establish the principle that science should proceed without political suppression. And so that has yet to be achieved. We are making MDMA into a medicine. Here's one of the reasons why. It's going to be coming from the octopi. I don't know, how many of you have heard about the octopi study? Okay, great. So this was a really amazing thing. There was a neuroscientist at Johns Hopkins who's from Turkey, Beryazar Klasinski, who works on our staff, is also from Turkey, and they had a bunch of conversations about it. And it turns out that I think it was like 50 million years ago or something like that, 250 million years ago, octopi and humans diverged evolutionary. And so the question was going to be, how do octopi react to MDMA? Are there the same binding sites? What do they do? And so this was a paper that was just published. They're generally solitary. They're not social unless it's mating season. And serotonin has been around for a long time, but it's unclear if the social behaviors in octopi are mediated in the same way as humans through serotonin signaling systems, but they do have the ability, it looked like, to bind MDMA. So they did this experiment where they have 3 chambers. The octopi is in the center, and then on one side is an object, an inanimate object, the other side is another octopus. And so they want to just see how much time they spend in each chamber. And without MDMA, they spend more time with the inanimate object than with the other octopi. So the experiment is that they put the octopus in a 10-minute bath of MDMA in the water. And they absorb MDMA, and then they repeat the experiment. And what they showed is that they spend more time with the octopi after MDMA than with the inanimate object. And this is true regardless of the gender effects. And so this suggests that MDMA has some fundamental pharmacological properties that go beyond even humans, that go through evolution, and that they spend more time after pro-social. MDMA has a pro-social effect. So if people might think, oh, all these people are just taking MDMA and they just want to party and they're saying it makes them feel closer or whatever, it seems like it really has a basis in pharmacology. So the octopi tell us that it works. What we know is that PTSD changes your brain. If you have PTSD, you have a hyperactive amygdala where we process fear. And you also have reduced activity in the frontal cortex, where we think logically, where we put memories in context, and there's a reduction in activity in the hippocampus, which also helps us process memories. So this is how PTSD changes the brain. But MDMA also changes the brain, and it changes it in almost exactly the opposite way that PTSD does. So MDMA reduces activity in the amygdala so that we can process emotionally challenging memories more easily. It increases activity in the prefrontal cortex so that we can think more logically. We can separate out certain signals. Somebody was attacked by somebody in a red hat. Whenever time they see somebody in a red hat, they get panicked. But then you can say, well, this isn't that situation. That requires a certain amount of rational thought. This is increased, and then there's more connectivity between the amygdala and the hippocampus under MDMA. So we can take emotionally charged memories and store them long term. And what happens then is that people, this is our basic understanding of how MDMA works, is that when you're in a position of safety and you're able to look at and think about, recall the traumatic experience, the mood that you're having is one of safety. Even though people are crying, they're shaking, still they're able to process it. It's not so overwhelming that they have to stuff the feelings. They're able to process it, and they're able to place it in the past instead of always happening. That's the problem with PTSD. It's always happening or about to happen, or it's right around the next corner. And so what happens then is that you reconsolidate the memory, which means that after you remember something, you have to sort of re-imprint it on your brain. And we're switching out then. So the episodic memory and the emotional memory are separate, but they get combined. And so after MDMA therapy, or while MDMA is actually having this effect, and you're thinking about it from a position of safety, the way you're recoding the memory is with a different, you've switched the emotional content. And also people's memory is increased for the trauma, because sometimes aspects of the trauma are so painful that you can't even bring them to awareness. And so they still have a negative effect always in your subconscious. So we bring these memories up to the surface through MDMA, then people are able to reprocess it and reconsolidate the memory in a different way, so that afterwards, when they bring back that memory, they've got it in the past and they have a sense of safety. That's part of their journey. It's not happening right now. So that's, we think, how MDMA actually works. It also increases serotonin, norepinephrine, and dopamine, but also prolactin and oxytocin, which are hormones of nurturing and love. And they help build the therapeutic alliance, and they help people feel connected and empathy again for others, which they've often lost when they've lost trust. So what I'm going to do now is show you a video. It's about a 10-minute video of an actual MDMA therapy, a series of MDMA therapy sessions in one of the veterans that was in our study. And so this is, this veteran was a Marine. He was 2 tours in Iraq, and he was struggling with rage. That was the big problem once he came back. And so I think a lot of people that we talk with don't really know the difference between what's MDMA, what's LSD, what's psilocybin. A lot of the veterans, a lot of the subjects don't even know. They just know psychedelic. It's all going to be, you know, bright colors and this and that. But this will give you a sense of what MDMA therapy actually looks like and how it works. Let's see if, great. Can you make it louder? There's a lot of captions anyway, so you can sort of see what's happening even if you can't hear it. Oh, great.
Happening, and everything was moving so slow. My mind was just racing at the speed of light. It was, I can really go back and visualize. I've never been able to visualize it so hard before. I can really feel what it was like, and there was this
You can see it's a male-female co-therapist team, which is our standard model. And this is Michael and Annie Mintover. We have people spend the night in the treatment center afterwards, and then there's integration sessions the very next day.
You can avoid a corner.
I just feel like I should tell y'all something that was just really amazing. It's hard to put it in words. That aspect of me that's just really rageful, and also, besides that image I told y'all about, the fighting with them, I had this image of it like in a jail cell. Yeah, like I had that part of me is locked up in jail, and it's just, it's dark, but it's got, bright red eyes and just really evil. And I thought of that, and I felt like I felt like I put that person there, and I went to it and just
That's the blood pressure machine.
opened the door and hugged that person, and then the eyes just faded away, and it no longer had kind of an evil look to it itself, and I visualized both of us just taking apart the jail cell and just, really becoming friends. And then I visualized that image I told you about of me, like it coming out of my hips and it stabbed me in the side and everything. And I just had a strong visualization of me like reaching up where the knife was on my side and taking it out, and took my hands off of its neck and didn't choke it anymore, and just really embraced it. And I don't know, I feel like, I don't know, part of me realizes that I think that I was taking that person and keeping him locked up because I was so afraid of him, and then that by putting him in that cell and keeping him locked up, that I was just making it worse for him. And I was really more beneficial if we kind of worked together. And I never realized how much I thought I was being a peaceful person, but I didn't realize how much I was punishing that aspect of me. I think maybe in Iraq I saw what it was capable of, and I think I was too afraid to, and a part of me just feels like so bad that I did that to him. I mean, I know it's me, but I just describing the last.
Part of you.
I don't know, I just got this amazing sense of just, I guess, wisdom. I really don't know.
Sounds a lot like wisdom to me.
It was really amazing. And even when I try and think of that really rageful aspect of me, like I can't even, I know it's there, but it just doesn't. I really feel like so much more at peace with everything.
Great.
Even if I try and think about Iraq and everything, I somehow feel like really peaceful about the fact that that's my journey. And that
Yeah, thanks for sharing that.
part of me I know this is part of the part of the drug, but when I try and think, am I going to be able to hold on to this this understanding and this somewhat of wisdom, this knowledge that I have now? Just asking myself that question, I feel like it's so profound that I don't think I could really get it. I don't know why I couldn't have come up with this on my own, but I'm glad I found it.
I'm glad too.
Wow. So this was about 10 years ago. And so he still is free of PTSD. And there's a book called Acid Test, LSD, Ecstasy, and the Power to Heal. And this Nicholas Blackton is the veteran that's written about in that book. So if you wanted to learn more about his journey, you could take a look at that book. Now I'm going to give you just a brief sense of the history of MDMA. So it was invented in 1912 by Merck. They weren't looking to get anything in particular. They were looking to evade a competitor's patent on a different drug, and they just found a new synthetic pathway and patented everything along the way, and MDMA was one of those things. They didn't do anything with it till about 15 years later when they gave it to some animals, and the animals didn't say, "Oh, I love my other rats." The animals said nothing, and so they decided there was nothing going on here with this drug, and they abandoned it. The next time we hear about it, or the next time it's actually used, is in 53 and 54, when the U.S. Army Chemical Warfare Service is looking for mind control drugs, and they did a series of toxicity studies with 8 different drugs, MDMA being one of them, and these were from mescaline to methamphetamine. And so it's a good way to understand MDMA is that it's like halfway between mescaline and methamphetamine, but different than either one. So it has the energizing properties of methamphetamine without the jitteriness. You can sit still with MDMA, you can meditate with MDMA. It has the psychedelic properties of mescaline, but it doesn't have that sense of, in higher doses of ego dissolution. And this results were kept classified though, and so nobody really knew about them other than a few small people, a few small numbers of people in the military. And then Merck in 59 decided to study MDMA yet again. Thank you. And once again, they found nothing interesting in it, and then in the 1960s, there was a drug called MDA, methylene dioxyamphetamine, which is a more psychedelic version than MDMA, and it was quite popular, and a lot of people did it. It was called Miracle Drug of America, and it was pretty great. But then it was criminalized in 1970 with the Controlled Substances Act, and all sorts of drugs were criminalized, and then different chemists were looking for different drugs that were chemically modified, but were would still be legal. And so Sasha Shulgin is the hero of this story, and he resynthesized MDMA and also hundreds of other drugs. And he found MDMA to have incredible therapeutic properties, and he gave it to Leo Zeff, who was what we call the Secret Chief. So the first book that MAPS ever published was called The Secret Chief, and then years later, a new edition we called The Secret Chief Revealed, after his family was comfortable revealing who it was. And roughly 500,000 doses of MDMA were used in therapeutic settings from the middle 70s to the early 80s. But some of those people that tried it in those settings decided that more people should have access to it. They should have access to it in more recreational settings, and they turned it into ecstasy. And ecstasy was in particular developed at the Stark Club in Dallas, Texas. And this is really where it became a party drug, and that's what attracted the attention of the DEA. So, as I mentioned earlier, I learned about MDMA in 1982 when it was both Adam was the code name for it as a therapy drug, Debbie Harlow was here, came to Esalen in 1982 and talked about a new drug. And so I learned about it from her. And so all of my progress, I would like to say thank you, Debbie. But what?
You only have to touch one other, so
Yeah. But at first, when she talked about it, I was not interested, because what she said is it helps you feel love, it helps you feel connection, it helps you talk to people. And I'm like, I feel love. I'm in love right now. I can talk to people. And then there was a group of people that were sitting around, I saw at Esalen, a group of people were sitting around in a circle doing the drug that Debbie had brought. And they were sitting around talking to each other. And I'm like, how profound can that be? You know, you take a bunch of LSD, you can't talk. So if they're talking, it must be like a low-level drug. So I was stupid enough to underestimate it, but smart enough to buy some. And then I took it home and did it with my girlfriend, and I was just absolutely shocked how deep and profound it was. And so with Debbie and others, since it was already ecstasy, it was doomed. And so we started thinking, we have a great opportunity here because we know the backlash is coming, but while it's still legal, we can run around, we can introduce it to various people. And so Debbie and I and a woman, Elise Agar, started another nonprofit before MAPS called Earth Metabolic Design Lab, which had been, a friend of mine had started it in association with Buckminster Fuller, but he wasn't using it, my friend wasn't using this nonprofit. So I took it over, and then Debbie and Elise and I used it. And what we did is we organized the advocates for MDMA, psychiatrists, psychotherapists, and we waited and we prepared. And in the summer of '84, the DEA announced that they were going to criminalize MDMA. And the way that they do that is they have to put a notice in the Federal Register. It lasts, you have 30 days to file for a public comment period. And we had, through Andy Weil, who was friends with a lawyer, Rick Cotton, who was from a big DC law firm. They agreed to take the case pro bono, so we had big support from a DC law firm. And so this is me spying on the DEA. Moments before I walked in the door to hand them this request for a hearing. So the DEA had no knowledge that MDMA was really a therapy drug. They only knew about it as ecstasy. So it took them totally by surprise, but they had to grant a hearing. And we were winning in the court of public opinion, which freaked out the DEA. And so in the summer of '85, they emergency scheduled MDMA while the hearings were still going on. This is Gene Hayslip, who is announcing the criminalization of MDMA. The irony here is that the first move against MDMA to criminalize it was itself illegal. The DEA did not have permission to emergency schedule drugs. And a bunch of people that got arrested in this early period of time were set free. So in '86, and there's Debbie in this picture too. In '86, I started MAPS. So it was clear that we weren't going to be able to protect this legally, and that we were going to have to make it into a medicine. And so I started MAPS as a nonprofit psychedelic pharmaceutical company with the main focus on MDMA. I was blissfully unaware at the time that no drug had ever been made into a medicine by a nonprofit organization. That didn't happen actually till 1999, and that was the abortion pill RU46, funded by Warren Buffett, the Rockefellers, John D. Rockefeller III, through the Population Council, and the Pritzkers. So MAPS was started in '86. The first 6 years, we had 5 different protocols from Harvard, from UC San Francisco, all over that were submitted to the FDA. All of them were rejected for MDMA, for either phase 1 or phase 2 protocols. And what happened in 1990, actually, is that Rick Strassman got permission for a study with DMT. The people at the FDA who regulated psychedelic medicine shifted to a new group, and a new group took over, and they decided to put science over politics. And so in 1992, Charlie Grobe and I were able to get permission for a phase 1 dose response safety study. And I understand Charlie was speaking this morning. And so this was a great triumph. So finally we were able to start with MDMA. What the FDA said is that they would review psychedelics the way they review any other drug. So even though by this point in time, tens of millions of people had taken MDMA all over the world, none of that data counted. We had to sort of recreate it from the beginning in an IND under the approval from FDA. And it took us from that study 8 years till we could do our first study in patients. And Michael Minhover came to me at a conference here in San Francisco that Ralph Metzner organized. It was the first ayahuasca conference, and Michael said, let's go set up an offshore clinic. He was a member of MAPS. I didn't know him. He'd already been through the holotropic breathwork training with Stan, and he was an expert in PTSD. And he said, let's go set up an offshore clinic somewhere, because he had just had a patient of his go to St. Kitts to take Ibogaine in a clinic that was set up there. And I said, I'm absolutely, totally not interested in doing that, that we have to go to the inside to change from the center out. We can't find some little isolated utopia somewhere. I don't know if those of you who've read Island by Aldous Huxley, but it was about creating an idyllic society, and where psychedelics are woven into it, and that was what Aldous was going to be writing about. And while he was writing about it, he actually changed his mind about the book, and then the plot ends with the outside world comes and destroys the island. So again, with global warming, with nuclear weapons, we can't find some little place somewhere. We have to make change from the inside out, and Michael was willing to do that. So we were able, though, to start a study in Spain. That was the first study with MDMA for PTSD, and unfortunately we got really good media attention, but that attracted the attention of the Madrid Anti-Drug Authority, and they shut the study down for political reasons. And so this was a paper of the abbreviated study. And then in the US, we got approval in 2000 also for a study with the FDA. But 7 different IRBs, institutional review boards, all rejected the protocol. We had FDA approval, but we couldn't get ethics committee's approval for this. It was super frustrating, and so MAPS started our own IRB. And I thought, we're an institution, we can do that. But then I thought, as a last minute, before I would actually go forward, it doesn't look as legit if you authorize yourself to do something, although it's possible. So I looked at the list of private IRBs, and there was one called the Copernicus Group. And I figured if anyone is sympathetic to science being blocked by politics or religion, it would be Copernicus. And lo and behold, yeah, they approved the protocol. We had to buy $1 million insurance policy to indemnify them. We spent about $60,000 on insurance just to insure them. We had to have an emergency room doctor and nurse sitting in the next room. That was another $50,000, $60,000. They never had to do anything, but anyway, they gave us permission. And out of this came some papers in 2010, 2012. The 2012 paper was really good because it showed that the effects were durable. They lasted 3.5 years at least. We just published in the Lancet Psychiatry about our study in firefighters, police officers, and military veterans. For political reasons, this was really going to be with veterans, but I thought, let's just say it's for firefighters and police officers also, so we'd be sort of sending that message. And then to our delight, we actually got some firefighters and one police officer as well. So what we learned from phase 2 was, first off, that MDMA works regardless of the cause of PTSD. The drugs Zoloft and Paxil that are approved for PTSD, they tended to work well in women but not in men, and they completely failed in combat-related PTSD. So the SSRIs are dependent on the cause of PTSD. But what we showed is that MDMA-assisted psychotherapy works regardless of the cause of PTSD. I thought I had a brilliant idea of how to do double-blind studies with psychedelics, and I got my dissertation approved, but this was a big part of it, which was the idea of low doses versus full doses. There'll be more confusion, there'll be more blinding, and I thought the problem was that the low doses, you want to make sure they're not too high so you get therapy benefits, because then it's going to be harder to show a difference between the two groups, but you don't want it to be too low so people don't confuse them. So we've done studies with all different doses, and what we found, to our surprise, was that low doses of MDMA have an anti-therapeutic effect, in that they activate people, but they don't reduce the fear enough. And so they still get better, but they don't get as much better as if they had just the therapy with no MDMA at all. So when we went to the FDA, I said, I thought I solved the problem. I said actually that there was an early president of Harvard 150 years ago. He said, never forget there's always a Harvard man on the wrong side of every issue. And I said, in this case, it's me. And I thought I solved the problem, but I didn't. And I said, there is no solution to the double-blind problem. Now, I don't necessarily say this is true for psilocybin. but we've demonstrated that it is true for MDMA. So you do get blinding, but it doesn't really give you the comparison with the therapy itself. And that's what we really want to know, is why bother add a drug if the therapy by itself can do the job? Why take a risk of adding a drug? So the FDA said, yes, they will let us compare MDMA or therapy with inactive placebo with therapy with MDMA. And what they said is, for situations like that, when you still want to get blinding, or you still want to eliminate experimenter bias. And the way that you do that is by random assignment. Everybody is similarly motivated, and then you have to have a very complicated system of assessing the benefits by an independent pool of raters. And so we were able to do that. We also demonstrated that MDMA could be safe in clinical settings and that there was a medium to large effect size. Now, what I want to share with you now is the fundamental difference between the research with MDMA and the research with classic psychedelics. And so what the research with classic psychedelics showed from the 60s and then more recently with psilocybin is that there's a link between the depth of the mystical experience and therapeutic outcome. The deeper the sense of the mystical experience, the more people heal from fear of death or from addiction or from depression. So we used the same states of consciousness questionnaire that was originally, this is slightly modified, but it was originally developed in the Good Friday experiment in 1962 by Walter Pahnke. And surprisingly, so 0.6, 60% is a full mystical experience, according to the way they decided this. And with MDMA, you can see that the mean is 0.46. So people actually score pretty high on when they get active doses. With the comparator doses, the mean is very low, 0.15. So we have enough, and we have about 1/4 of the people actually had a full mystical experience according to this questionnaire. But we showed absolutely no correlation between the depth of the mystical experience and reduction of symptoms of PTSD. So what I think that means is that for PTSD, you need to be anchored in your biography. You need to have the memories from your specific trauma, from your ego, from your life, and you need to reprocess them in the way that I've just described. It's not about having a mystical experience going beyond your ego that helps you really overcome trauma from your life. And so that's why the way in which we do the therapy, and our method, we're not trying to steer people to a mystical experience. And in our therapy, roughly, it was an 8-hour session. Roughly half the time, people have their eyes closed, listening to music, processing in imagery and metaphors, thinking about their lives. And the other half of the time, more or less, they're talking to the therapist in no particular order, when it happens. With psilocybin or LSD, it's around 90% of the time people's eyes are closed, and around 10% of the time they're talking with the therapist. And usually this is not long talking like the way you saw with the MDMA patient, it's just a few words. So this really is, I think, a key to how therapy should be done with MDMA for PTSD. So based on all of this work, 30 years from the time I started MAPS, 2016 is when we had the first end of phase 2 meeting with FDA. This was November 29th, 2016. And this is where we want to go to phase 3. Phase 3 are the studies that really are the large-scale studies to prove safety and efficacy to get permission to market a drug. And we presented data from 107 patients from Israel, Switzerland, Canada, and the United States. What we showed is that in the placebo group that either got this low-dose MDMA or inactive placebo with the therapy, after 2 sessions, 23% still no longer have PTSD, which is really good. These are chronic, severe, treatment-resistant PTSD patients. And this is demonstrating that our therapy is actually somewhat effective, comparable to other non-drug psychotherapies. But when you add MDMA after treatment, you're up to 56%. It more than doubles. But what's even more remarkable, and this is at the conclusion of treatment, is 2 months after the last MDMA session. We also do a 1-year follow-up, and what we find is that at 1 year, 2/3 of the people no longer have PTSD. So there's a healing process that started. It takes a while, even after the primary outcome measure, which is the 2 months after the last MDMA session. So that 2-month point is what the FDA is going to evaluate our phase 3 data on. But then the 1 year is really what insurance companies are going to be looking at. Will they cover it? Does it last? Is it durable? So after this meeting with the FDA, they said, yes, we can go to phase 3. But what we did is, there's an option that the FDA has called special protocol assessment, where most pharmaceutical companies don't do this. But if you want to, you can debate and discuss every aspect of your phase 3 design and all the other information the FDA is going to want to see to make it into a medicine. And if you come to agreement, you get an agreement letter from special protocol assessment. And that binds the FDA. They're legally required now to approve the drug if we get statistically significant evidence of efficacy and no new safety problems arise. And since we have got so much information on safety, there's 5,000 papers in Medline under MDMA or ecstasy. So we managed to get this. This did delay us about 7 months, but it was really important. And so we got the special protocol assessment, and this is the approval that we got. As I said, they gave us approval to do inactive placebo. There's 3 MDMA sessions, 1 month, 3 to 5 weeks apart. And there's 12 non-drug psychotherapy sessions, 3 to prep before the first session, and then 3 after each MDMA session for integration. And we're going to start, everybody's going to start with 80 milligrams. We also give half the initial amount after 2 hours to extend the plateau. It doesn't really make it stronger, but it gives more time for people to process. And then there'll be a discussion, the second session. We're assuming that almost everybody will go up to 120 milligrams with a 60 milligram follow-up after 2 hours. But if there's some reason that the person or the therapist think they should stay at 80, they can stay at 80. And then the third is also going to be a similar discussion. And so that's the protocol that's been approved. But FDA went even better. They granted breakthrough therapy. This was in August, about a month after we got the special protocol assessment. I knew that we qualified for breakthrough therapy. This is the most important program that the FDA has for the most promising drugs, but it's very public. And I thought, is the FDA really going to want to publicly say yes to MDMA being a breakthrough? And so they did. Maybe we should just tape it or something. Well, so they did. And I don't know how many of you have heard, but just several days ago there was a press release. FDA has granted breakthrough therapy for psilocybin. For treatment resistant. And part of the reason that they did this breakthrough is that there's pharmacotherapies, Zoloft and Paxil that are approved, but they require daily dosing for months or years at a time. They reduce symptoms, but they don't cure the problem. And then if you stop taking them, the problems come back. And there are psychotherapies that work quite well for a fair number of people, but for others, they can be re-traumatizing. And so there's high dropout rates. And just to give you a sense of it, this is over 2 years old, but as of June 30th, 2016, there was 868,000 veterans receiving disability payments for PTSD. And there was almost 600,000 more veterans receiving disability payments for anxiety, depression, other mental health disorders. So there's just a massive number of people that are treatment resistant. The last time they put out a number of how much it cost, it was $20,000 a year. That was in 2004. So at that rate, assuming it's still today, it's $17 billion a year that the VA is spending on disability payments for PTSD, and $29 billion for all mental disorders. Yeah.
Question about the phase 3 protocol. Is there no crossover in the phase 3? There's just an active arm and a placebo arm?
Well, there is a crossover, yes. But the way in which, I think we'll have to plug this in somewhere. If you guys, but so the way we did phase 2 is that everybody got 2 sessions, then we uncovered the blind, and those people that had the placebo could then go right directly into stage 2, which was open label MDMA. So what the FDA said now is, because of these issues of blinding, that we're going to have to complete the entire study. So there's 2 phase 3 studies, each with 100 people, and 50 in each group. And then we have to complete all of them from start to finish and have the 2-month follow-up for all of them, and then we uncover the blind, and then the people who had the placebo can go through it again. So that's going to be harder for people to do. It's going to be a longer period of time that they're going to have to wait and try other things. But that's just the way we need to do it with the FDA. Now, after we had the breakthrough therapy, we had meetings at the DEA. So this, after our meeting, by the way, which went really well, we went downstairs and there was the DEA store. And they had these patches. These are only one of a series of patches. They must have contracted with like a Grateful Dead artist who made these incredible patches that are really quite beautiful, actually, although this is their patch about dancing with darkness for MDMA. But we met with the DEA on December 19th to talk about what's called expanded access, and also about more licenses that we're going to need for DEA to give to Schedule I licenses to people working on phase 3. Expanded access is what's called compassionate use. And what that means is that if you have a disease that nothing has helped, and there's a drug that's being studied for that disease, you should be able to get access to this drug at your own cost and at your own risk, but nothing else has worked. And that's called expanded access. President Trump just signed a bill called Right to Try, which basically cuts the FDA out of it and people deal directly with the pharmaceutical industry, and that's only for terminal illness though. The FDA doesn't like that, but they do like expanded access because the FDA is still involved. There's still a bit of safety data gathering, and DEA was fine. A beautiful little moment was, there's 2 DEA buildings, and the land up above it was being renovated, and so we had to go through the garage. So, and you can only go with an escort with the DEA into the DEA building. So our DEA official escort was taking us from one building to the other, and she said, we're going to have to go through the underground to get to the other one. And I said, all right, we're comfortable in the underground. So then we get to the other building, and we were up to the 6th floor. And for some reason, on the 2nd floor, the elevator opened, and nobody got in and nobody got out, and none of us had pressed the 2nd floor, and then the doors closed. And as we're going up to the 6th floor, our DEA consultant reminded me that the courtroom is on the 2nd floor. So the last time I was at DEA headquarters, I was on the 2nd floor in the courtroom suing the DEA. So we had this momentary opening of this past, then closing, and then we went up for this collaborative meeting. It was just a really meaningful little coincidence. The next day we had a meeting at the FDA, also planning under the breakthrough therapy, planning also for expanded access and for phase 3. These are all of our phase 3 sites. We have 15 sites all over the world for phase 3. Now we've also been, June 12th, we were at the European Medicines Agency. So we're trying to bring MDMA to Europe as well. It's going to be $27 million to make MDMA into a medicine in the FDA for phase 3. We've raised all of that in donations. And what we worked out here is that the European Medicines Agency will accept data from the FDA. So it's only going to be about $9 million to make MDMA into a medicine for Europe. And Europe has more people than FDA. And one of the things that was so touching for us is that the European Medicines Agency said, we want you to enroll refugees and migrants in the study because there's so many of them. So we're still in the fundraising phase. We have 900,000 of the 9 million, and we're hoping for the rest.
I wonder about the expanded access in Europe. Is it going to be possible or not?
Well, it's going to be a country-by-country negotiation. And so we've just been granted expanded access in Israel for 50, so 50 patients can get access under expanded access. They do have that. And so I think we'll be able to do that. But what they want to know is that you're not slowing down phase 3. And so I think and there's only those therapists that we've trained that can be providing this expanded access. So first, we're going to make sure that they're working on phase 3, and so what we're doing right now is we're going to start training more therapists for expanded access in the U.S. And actually, expanded access can start next summer, we think. And so there's a lot of people then that can set up clinics in different places. The thing about expanded access is patients can pay for it. It won't be covered by insurance until it's approved, but expanded access is a big important way. We have over 20,000 people with PTSD who've signed up on our website to be notified when phase 3 starts, and phase 3 is only for 200 to 300 people. So there's millions, as I've shown you. There's about 9 million people or so with PTSD in the US. But yes, we will try expanded access in Europe as well. Just to give you a sense, I've just spoken about PTSD, but we've done a small phase 2 study with Charlie Grove and Alicia Danforth on MDMA for social anxiety in adults on the autism spectrum. They just published it last month in Psychopharmacology. There's really good results. We've also done a study with Phil Wolfson and Julaine Andries with MDMA for people with anxiety from life-threatening illnesses, and they're working on that paper now. There's a project in England with Ben Sessa, MDMA for alcoholism. So this is the first study that's looking at MDMA in patients that we're not funding. It's really good, and what they're basically saying is that trauma is what drives people to drug abuse a lot of times, running from trauma. And if you can deal with the trauma, then they're not going to be as motivated to drug abuse. There's a study starting very soon at Yale, and this is a mechanism of action study, taking people with PTSD, giving them MDMA, sticking them in a scanner, and seeing how their brains operate under the influence of MDMA. So we have healthy volunteers have taken MDMA in the scanner. That's why I was able to present you the data before, but no PTSD patient has ever gone into the scanner under the influence of MDMA. So this is at Yale, and Yale is also one of the National Center for PTSD sites for the Veterans Administration. We also are doing studies with VA-affiliated therapists. So again, we're paying to educate the VA therapists about what MDMA does, and we're also saying, see if it can blend with the therapies that you've developed. So the first one is this cognitive behavioral conjoint therapy. Conjoint meaning couples, where one member of the couple has PTSD and it affects the relationship. And so we've done 6 couples like that, 6 dyads, and it's been remarkable at how well it's helped the person with PTSD heal, but also how it's strengthened the relationships. And so you can only get drugs through the FDA to treat diseases. Couples therapy is not a disease. It might feel that way sometimes, but this is the way we're sort of backing into learning about MDMA for couples therapy. We're also working with Barbara Rothbaum at Emory on blending MDMA with prolonged exposure. And we're working with Ann Wagner and Candice Monson to blend MDMA with cognitive processing therapy. These are the 3 main therapies used by the VA. And for cost reasons, and also perhaps it even works well, we're starting to look at group therapy. And since it's about Halloween, I got this image for you of group therapy. So we got a $500,000 grant pledge for us to do group therapy in veterans. So we're so busy, we're still working on the protocol. It'll be a while before we start it. But this is a really important area to move into, is how can we optimize and what can we learn? Maybe group therapy works even better. I think for severe chronic treatment-resistant PTSD, individual therapy is going to be required because there's shame, there's difficulty. I think it'll be very difficult for people to do it in a group, but we'll see. And then we're also trying to do projects with psychedelics for conflict resolution. There's a bunch of Israelis, Jews and Israeli Arabs that are taking ayahuasca together. Taking MDMA together. Yeah. So we want to study that. So that's a bit about the history. Now, going forward, and then we'll have more time for questions. So the expanded access, compassionate use, I mentioned this. So how does the drug actually get approved? The FDA has a program called REMS, which is Risk Evaluation and Mitigation Strategies. And this was actually developed for thalidomide. Thalidomide was the main bad drug in the early 1960s that was given for women for morning sickness that caused terrible birth defects. And so the FDA blocked that from becoming a medicine in the US. The only FDA official that ever won the Presidential Medal of Honor was the woman at FDA that blocked thalidomide from coming into the US. Now thalidomide is a medicine. It's approved by the FDA, and it's good for leprosy, it's good for certain kinds of cancer, for constricting blood vessels. But there's a whole set of policies on how it's used to prevent it from causing more birth defects. And so the FDA's developed that they can have special regulations for drugs that have unique risks. And so what we're talking about with REMS is that only those people that have been through our training program can prescribe the drug and can be in direct contact with patients, because the drug is not the treatment. It's the drug-assisted psychotherapy, and it will only be administered in clinics, in clinic settings, only under direct supervision. And it's under those circumstances that both FDA and DEA are comfortable letting us go forward. It's fundamentally different from medical marijuana, which is you get a month's supply, you take it at home, who knows who you give it to. You know, it's a nightmare from a drug control perspective from the DEA. But MDMA and psilocybin will be easily controlled. Similarly, ketamine is as a medicine for depression. You know, well, now they are giving it to people, you know, in nasal sprays and things like that. So that's a little bit challenging from a regulatory point of view. But anyway, these are the REMS. This is how it'll be. Then we're going to start clinics. There's 14,500 drug abuse treatment centers in America, 6,100 hospice centers, 33,000 yoga Pilates studios. So there will be thousands and thousands of psychedelic clinics. Some of them will look like this. Some of them will look more like this. You'll go to Google Maps one day and you'll say, where is my nearest psychedelic clinic? This is what you'll find. These are, of course, all the ones in Europe. Now, one of the things that we're saying to donors and to others is that we're in a unique situation as a nonprofit, because we're actually talking about having a product at the end. And so what we're saying is that we can become a sustainable nonprofit if people can help us medicalize MDMA through the FDA, through the European Medicines Agency. We should be able to make money selling MDMA. Now, MDMA is invented in 1912. It's off patent. And in the middle when I started MAPS in '86, there was another group that started NDA International, which was to make Ibogaine into a medicine. And they decided to do it in a for-profit way. And they got a use patent on Ibogaine for opiate addiction. And unfortunately, they all started suing each other, the researchers. They all started thinking about profits, and it destroyed the whole thing. So in the late 80s, early 90s, I contacted the same attorney that worked with Ibogaine, and I said, I want you to develop an anti-patent strategy so that nobody could ever patent any use for MDMA. And so we have done that, and so there's no use patents really, unless somebody can think of some new weird use that nobody's ever thought of before. But Ronald Reagan did something that I appreciate, one thing. And in September of '84, he signed a law that provided incentives for developing drugs that are off patent. And these incentives are called data exclusivity. So that means that no one can use your data to market a generic in the US for 5 years, in Europe it's 10 years. Somebody else could generate their own data. It's not like a patent or anything like that. But chances are we will be the only ones likely to sell MDMA for PTSD for this period of 5 years, this period of data exclusivity. And if you end up doing studies in pediatric populations, you get an extra 6 months data exclusivity, and nobody can apply for a generic until this 5.5 years is over. It takes at least 6 months for the FDA to review the application. So chances are we're going to have 6 years of data exclusivity, 10 years in Europe. And so this is what our structure is. So we've created the Public Benefit Corp. So we're trying to model a new way to market drugs, a new way to market pharmaceutical drugs. Selling MDMA for a profit is not something that can stay inside the nonprofit, because it should be taxable. And eventually, depending on how many therapists there are, it could be a fair amount of money. And so it has to be in a for-profit company that we sell MDMA. But one of the things that you hear about people's concerns about the legalization of marijuana is we don't want big alcohol, big tobacco getting involved. Now we see Coca-Cola and all these companies are talking about cannabis-infused drinks. And so the concern is you have the for-profit, profit maximizing behind psychedelics or behind marijuana, and there's going to be a lot of negative externalities for there while some companies are making money. And so I don't think all companies act like that. I would say that I don't think Compass Pathways, that's for-profit for psilocybin, is going to act like that. But the new model for us is the Public Benefit Corporation, which is a modification of capitalism. There's several thousand of these companies, and they permit you to maximize public benefit nonprofit. And so we've created the Public Benefit Corporation that will sell MDMA, that does our research, but it's 100% owned by the nonprofit. And so there's no private gain. People make donations to MAPS, they get a tax deduction. MAPS invests in the Public Benefit Corp. The Public Benefit Corp will then make MDMA into a medicine, sell it for a profit, a reasonable profit, not an enormous profit, and will then reinvest that money in other research according to the mission of MAPS. So that's our big picture. We've come a long way. This was Oprah in 2001 and MTV, MDMA supposedly causing holes in the brain. We started changing the narrative. This was the peace drug in the Washington Post. And then Oprah, 10 years after, in O Magazine, permitted one of her senior writers to do a story on MDMA and actually take MDMA with an underground therapist and write about it in the magazine. And it was just like one sentence that's illegal, but the rest was how much she learned from the experience. And this was the graphic, which was MDMA as a magic pill. It's pro-MDMA propaganda, but at least we've made progress from holes in the brain. And this was one of my favorite articles recently, Lucy in the Sky with Doctors. And marijuana that went medical, then mainstream, are psychedelics next. And they said, as the marijuana debate shows, attitude shifts that barely seem possible can sometimes become inevitable. And I think that's where we're at with psychedelics. We've had massive amount of media. And so I'm going to now play you a short clip from Fox News, just to give you a sense of how we've come.
According to a new study, soldiers with PTSD using the illegal drug known as MDMA or ecstasy cured the condition within weeks. This is key because I don't think I've ever seen the word cured in a highfalutin medical journal. Usually it significantly improves, but never cures. Now the study was small, 26 patients, but the message is big. When a substance has a real effect, meaning it changes you, it also frightens people. Drugs like ecstasy are illegal because they work. And when things work, they are hijacked for other purposes, to have fun, for example, and then people die from taking too much. And that's when the law breaks in and bans it. This has happened to many substances that could have helped millions of people. Just decades ago, MDMA showed real promise in psychotherapy. Then it got banned. But times are changing. We realize it's absurd to punish a substance and a patient because the substance has potential for abuse. Instead, let scientists test them on various hard-to-treat illnesses. You want a crazy example? Try botulinum toxin. It's a substance that's deadly. Yet instead of reporting its lethality, newscasters shoot it into their faces. It also reduces wrinkles when used wisely. It's poison! Other drugs like Special K are now being tested on depression. Pot's also being tried on PTSD as well. So with scientific study comes progress and relief. So why not send a drug down that path instead of leaving it on the street? All right, you know what I think is smart, Dana? If you look at a lot of these studies, it's the choice of the patient. If you use veterans, people have an innate sense, Democrats and Republicans, that we owe it to them.
Suggesting.
Yeah, so it's a great strategy. Like if you just did, this is a study of depressed IT workers. No one's, people are gonna go, that's too bad.
No, because also we have thankfully learned enough about PTS that
your computer's never getting fixed.
Yeah, I know. Sorry, IT workers.
I think we've learned enough about PTS to understand just how damaging it is to somebody and how the terror, especially also the suicides.
Yes.
Okay, so yeah, I agree with this. One thing I think that could happen because of this study and the concern about it being misused and abused, it's the possibility of new delivery devices. So, for example, if you find out that it's something that works for a patient with PTSD, a veteran, is there something like an implant?
Yeah.
Something that where the doctor is in charge of it.
But
It's
she's
not something
missing
that's
the
like
point.
getting
It's
pills
not a
out on the
daily
street.
drug.
Right.
And there's a lot of new innovations like that happening. And Scott Gottlieb, who is the FDA commissioner under President Trump, is really forward-thinking in this regard. So it's possible that something could actually happen.
I hope so. Juan, they're looking at all sorts of drugs that we've always been taught in the 70s, like when we used to watch Dragnet. Remember, every drug was bad, acid, but now they're looking at these things because they see they have potential for many illnesses.
Yeah, I mean, marijuana is at the cutting edge of this, and it's again, it's older people who find it's good for pain relief, relaxation, and I think it's lots of people who are voters. And so I think you're seeing the country change on marijuana in a radical way in our lifetime.
While they're voting?
I don't know. It explains a lot. It explains November 2016. You know what? struck me was thinking when I first read this, I think, oh boy, this is not, you know what, this is like some big pharmaceutical companies come to, and I get through the story and says, no, not at all. This is Association for Psychedelic Studies,
right,
which was created in 1986 after MDMA or ecstasy had been banned.
Exactly.
So I don't know. So then I thought, well, so were these people supporters of ecstasy? Is that why they were created?
I think that there was a group of psychotherapists who were really, really angry when a valuable tool was taken from them. And I can't remember the guy who's in charge, Doblin. I think Doblin. All of this. And, but that's how it happened. They were ticked off that the government stepped in. And,
but you know, it's interesting to me that, you know, previously most conservatives would have said, oh no.
Absolutely.
Oh no, no, no. But now, given the veterans' needs, and because it's a crisis for the veterans, all of a sudden the conservatives are like, oh yeah, well, let's try that.
I think that was the key, I think, Kimberly. What do you think?
Yeah, I think that, you know, this is part of the overall, you know, complex problem that we have facing veterans, those that are coming home, so many more of them surviving injuries that otherwise that would have been life-threatening or ending in TBI, traumatic brain injury, the depression, anxiety, the homelessness, the things that come with serving, being away, families broken up. It's very difficult, but I think there is definitely a genuine interest in trying to do the best for our men and women that serve, and part of that would be allowing them maybe exposure to some other different types of remedies or drugs or therapies that might be beneficial to them. So many of them can seek, you know, the help of the VA as a, you know, a last resort. And I think that's why we really need to do something about it and put in somebody very strong and great there to do a wonderful job for the veterans and really help them.
You know, Jess, did you ever think you'd be doing a pro-ecstasy segment on Fox News?
No, my mind's spinning right now, and I haven't taken any ecstasy. LSD was used in the 40s and the 50s and the 60s in small clinical trials to treat alcoholism and PTSD and depression, and then it was banned because people would abuse it, and now it's getting a second look because of this. The brain scanning imagery is so much more detailed. You can see if it's MDMA or a small dosage of LSD, what effect that has on the brain, and it gives the scientists and the medical professionals a more accurate read on what it's actually accomplishing. I think every option should be on the table. If it's a therapy dog, if it's psychotherapy, hyperbaric chambers, medical marijuana, MDMA, let's get it all fixed, and something that's taboo shouldn't prevent doctors from trying to help
be the
with radical
conservative on
therapies.
this, though? I just don't want...
This is getting weird.
I know, but I just don't want... Ecstasy can kill young people. They go to these parties, these raves, and
but
you
a
hear
small dose in a clinical trial,
you know, be careful.
Well, no, that's good. That's important. You don't want people to get the wrong idea about it. But it just goes to show you, once again, it's the men and women that serve that are the bravest to try other remedies and treatments are going to help other people, right?
Exactly.
What would you do for your family member? That's the point, you know?
Exactly.
So we've clearly got bipartisan support. And so because we started late, I have just a few more minutes. I know it's 9, but what I want to talk about now really is just what could go wrong. And this will be very brief, but I think it's really important. So one thing that could go wrong is we could, the advocates could be very arrogant and think we know best. And here's what was said about Timothy Leary in 1961. This was a critique of the Harvard Psilocybin Project. Just at the end is how to prevent the absorption of one's own thought processes from creating social withdrawal, insensitivity, impulsivity, and an unrealistic sense of omniscience. And I think that is a danger, particularly I think more from ketamine than from other things, the other psychedelics. So we have to be careful, we have to be humble. What else could go wrong is the backlash. You know, the return to the law and order and the drug war escalation. And as I said before, LSD was a symbol of cultural rebellion. Timothy Leary was the most dangerous man in America. The Beatles took a bunch of LSD and were protesting Vietnam. But there's this quote from Ehrlichman. This was an incredible quote in an interview. We knew we couldn't make it illegal to be either against the war or black, but by getting the public to associate the hippies with marijuana and blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. Wow. Right? But drugs as a symbol of the counterculture is no longer really what people think about. that was then. You know, we've got, as I said, our senior retired DEA official who's working with us. The aging of the baby boomers. Not all baby boomers have dropped out and lived on a commune and grow soybeans. You know, we have Steve Jobs, the creator of the most wealthiest company in the history of the world, Apple, acknowledges his use of LSD. So we've gone from Woodstock to Steve Jobs. People are changing their minds about psychedelics through ketamine. You know, ketamine is now being used for depression, according to the former head of the National Institute of Mental Health. Recent data suggests ketamine given intravenously may be the most important breakthrough in antidepressant treatment in decades. That's changing people's attitudes. We did receive $5.5 million from a Bitcoin donor who was prescribed ketamine off-label to treat borderline personality disorder. And he says, in fact, I came up with the idea for the Pineapple Fund during a ketamine IV. As I started regaining motivation to make an impact on the world. He gave away $55 million worth of Bitcoins within 3.5 months. And we managed to get $5.25 million from him. And part of it was because when he was under the influence of ketamine, he wished that he would have been given therapy too. He felt that he was kind of on his own, and he thought that if he had been given emotional support, he could have made even more progress. And when he found out that we were doing MDMA-assisted psychotherapy, he said that's exactly it. It's the combination of the drug and psychotherapy. He said the combination of the substance with therapy has the most impact. My experience with ketamine is closely linked to my support of MDMA PTSD research. And this issue of the MAPS Bulletin has a longer article from Pine about why he decided to create the Pineapple Fund. And he gave us $1 million, then he gave us a $4 million matching grant. So it's no longer anymore MDMA or psilocybin is going to produce counterculture rebels. The concerns are more about sending the wrong message to children. This is the Students for a Sensible Drug Policy. I love this process. Have you talked to your parents about drugs and drug policy? Take the pledge to have the talk. This, of course, is mimicking the anti-drug propaganda. You know, the concern is catalyzing non-medical use. We haven't seen that from marijuana. In marijuana legalization in medical marijuana states, there's not been an increase in use by young people. And to deal with young people having difficult experiences, we've created the Zendo Project. And I think what will even more further ease parents' concerns about their kids is we're being required by FDA to do studies in pediatrics populations. Once we get MDMA approved as an adult, we are being required to work with adolescents with PTSD.
Wow.
And then if it works with adolescents, we're being required to go even younger. So if it can work with octopi, it could work with kids who don't necessarily have a lot of verbal skills, but who have been traumatized. So I think that it's mainly, the worry is what do parents think about their kids, and that's what we have to focus on as the likely cause for backlash. Another thing that could go wrong is we could be burning, not building bridges. And some of the bridges are to the right wing. So we received $1 million from Rebecca Mercer, from the Mercer Family Foundation. For those of you who may not know, they were the main funders of Trump and Steve Bannon, and they owned Cambridge Analytica, which was a disgraceful situation impacting our election, and also their minority stockholders in Breitbart. But they're caring about veterans, and so we received $1 million over 4 years from Rebecca Mercer for our work. And I thought that this was absolutely incredible to try to solidify our move forward. And so I got a fair amount of criticism for taking this money from Rebecca Mercer. So I really think we have to build bridges. We have to reach across political divides. And it's the New York Times article that reported on our study in veterans was the one that got the Fox News. It was the day before the Fox News article, and in the New York Times article, they had a sentence about Rebecca Mercer donated $1 million. And reading that gave them the permission to be so positive about it. And Kimberly Guilfoyle, the person that was talking at the end, she's now in a romantic relationship with Donald Trump Jr. So I think we've got bipartisan support. This is John Lubecki on the right hand. He was one of the veterans in our study. This was at a conservative conference with Steve Bannon. Steve Bannon was also a veteran. He's now sympathetic with what we're doing. Psilocybin, as I mentioned, was given breakthrough therapy just recently. So bipartisan support has really resulted in a lot of support, but we should not burn bridges with the for-profit efforts that are coming in to develop psychedelics. I think that the last time I was here in this room, it was a conference about, I came here to be attacked in person. Some MAPS staff were reluctant to be here without me because people are saying, why should we work with a for-profit company? So work with means that we share information. We don't own any stock in Compass Pathways. We're not connected in that way, but we believe that as a nonprofit organization, our job is to share information with the public freely. And if somebody wants to use it, we want to help them use it to make drugs into medicines. We want to help USONA, which is the nonprofit company trying to make psilocybin into a medicine. We're willing to help Compass Pathways. And I think they're doing good work. I don't think we should say that they're evil or they have Peter Thiel as one of their donors, so they're being attacked on the behalf of it's guilt by association. But I'll just say, let us watch what they do and see how it turns out. And my belief is that they are going to do an incredible amount of good in changing attitudes of the mainstream, and they will bring these drugs to market, I think, sooner than USONA will, and will help depressed patients. So I don't think we should be burning bridges with either the right wing or with for-profit companies. What could go wrong is a lack of diversity. I think that's a real big problem. Of the 107 people that were in our phase 2 study, all of them were white. I was surprised at that because a lot of the veterans are African Americans, and I thought a bunch would apply, but that didn't happen. And so now we're working with Monica Williams, who is an expert on racial trauma. And so, and we're also going to be getting a grant. We haven't got it finally confirmed, but we're going to be getting a grant, I believe, from the Open Society Foundation, from George Soros, for a special training for therapists of color. And so we're going to do what we can about the diversity problem. And then what could go wrong? Post-approval problems. Well, I think the main area there is going to be patients that have bad outcomes, either patients that have been treated by therapists that are not properly trained, and we're going to try to avoid that by properly training them, or patients that end up having sex with their therapists, because that's a big issue. That's one of the reasons, not the main, that's one of the reasons why we have 2 therapists, a male-female team, to further create a sense of safety. It doesn't work all the time, but I think that we have to be very careful how we scale this out, because initially, whether we get to continue this or not will depend on the first bunch of patients. So again, this is about not maximizing profits, but about maximizing public benefit, and to make sure that once it's really made into a medicine, that the therapists are qualified, and that we're paying good attention to making sure that the treatments are good. And we're going to have complaint systems and patient bill of rights and all sorts of stuff we're going to do to try to ensure quality. We have to be a little bit careful about how we advertise, ethical compliance and pharmaceutical marketing. You can imagine all sorts of different kind of ads. Are you overwhelmed with anxiety? Ask your doctor if MDMA therapy is right for you. This is the ad for CIS. Ready for a new career in psychedelic-assisted therapy? California Institute. Did you see that? Of course, this was graphically manipulated. This is not, I don't think we're actually doing this quite yet, but how long do you think before you're actually doing this?
5 years.
Okay, or drink ayahuasca. So we have to be, again, careful with our public presentations, but if we do it well, it can become more than a dream. And one day, I will have my license, and I'll be a psychedelic therapist. So, thank you. So, now if there's more questions, okay. Yes, Ron?
Rick,
here, just so people, water.
I think many of the people in the program for psychedelic therapists here are excited about applying for expanded access permits.
And as they try to think about a business model for that, one of the major challenges they face is how to get reimbursement when there's no insurance system yet. And you mentioned also the goal of greater diversity, which can make it even more difficult for them to provide services to a population that may be least able to pay. Any suggestions or thoughts for people as they try to think through how to do this to be able to pay for it?
Okay, well, first off, think about all the people that go down to Peru or Brazil for ayahuasca. And those are mostly more or less healthy people, but they're all paying for it themselves. Then think about all the ibogaine clinics. Ibogaine is illegal in the US, but legal in most countries. And so there's ibogaine clinics in Mexico and Canada and in England all throughout, and people are paying for it themselves. So a big part of it, I think, will be patient self-pay. But the other part is that we're going to try to find donors who are willing to subsidize the cost for a particular population. So for example, we just got it turned out to be, it was in stock, it meant to be $100,000, it was $94,000 before we were able to sell it. And it's from a woman who wants us to supplement expanded access in North Carolina and South Carolina. We're working with other people who are trying to find mega millions to supplement the treatment of veterans. So I think that what we'll do then is if these grants materialize, they'll go then to pay the therapists. But I think that we also really have to be negotiating as soon as possible, and we already are starting this with insurance companies to try to help cover it. I think that it would be good for some people if they're willing, So in our training program, right now, in the supervision study, so we pay for that. So we pay for everything for therapists for research. But for expanded access, we're going to require the new male-female co-therapy team to work with their first patient for free while we give them supervision, on the theory that they're still learning and that everybody gets something out of it. So all the new teams that will train, at least one person will be treated for free. But I think, you've put your finger on it, that is the crucial issue. Not only how do we pay for expanded access, but how do we get it so insurance covers it afterwards? And so what we've been looking at, and this is a little bit interesting from the data from phase 2, is that most of the drop in the PTSD symptoms is after the first MDMA session. Then let's say that's somewhere like 60% of the drop, and then around 25% of the drop in symptoms is after the second session, and then 15% or so is after the third session. So these are just the averages. There's some people that are high on dissociation. Those people tend to need more therapy. But our standard model is going to move from 3 sessions to 2 sessions, which should dramatically reduce the cost and also leave people a lot better. So our Israeli study, which was only 10 people, was only 2 sessions. Our first study in the US was about 9 people with 2 sessions before we changed it to 3. So I think that we'll think of it as a standard model of 2 sessions, and those people who need it will go more, but that'll reduce the cost some. And I think the other big thing, and this is where CIS comes in, is that we talk about a male-female team, a 2-person team, but one of them needs to have a license, but the other does not. The other can be a student. So ideally what we're going to have is 2-person teams where one person is either working for free to get their required hours to get licenses, or they're working at a very low rate compared to the other person who has the license. So I think that that's where we'll find more and more students who will be willing to do this to get the experience. Yeah.
How do our license go together? Like what we're doing the training in the MAPS, how does that go together, and what do we need to continue with you?
Well, so in the CIS program, for training therapists, there's we've sort of imported our week-long training watching videotapes. So everybody who goes through the CIS program automatically will have done that piece of our training. But there still need to be the experience where they take MDMA themselves in a therapeutic setting. So Janice and I were talking earlier today about a protocol that we can eventually develop so that CIS can be giving, in a legal protocol, people can receive MDMA and psilocybin. and other students will be sitting with them, different things like that. So the other thing is that we've trained all the therapists we need to train for phase 3 for FDA. We're starting phase 3 in November, and we think it'll run for 2 years. Now, our next training, the one we just had was for European therapists. We have another one that's probably gonna be the end of January in Israel, where the Israelis have approved expanded access. So we're gonna be training a bunch of therapists for expanded access and a few more therapists for Europe, and then in March, we'll start training for expanded access. And every 2 months, we'll have this week-long training. But the CIS people have already been through that. And so the backlog for us is giving MDMA to therapists. We only have a few sites where that is taking place. And one of the things that makes me super happy is that we have a site in Boulder, Colorado, and a site in Charleston. But George Greer, he was an early pioneer of the work with MDMA, and he has just retired, and he said that now that he's retired, he only wants to do things that he would do for fun, not for money. And I said, would you be willing to set up a site in Santa Fe to give MDMA to therapists as part of their training? And he said, yes, I will do it, but only if you don't pay me. So I said, all right, we will not pay you. And so we're expanding the number of sites to give MDMA to therapists as part of their training. And then the challenge is going to be that expanded access is a particular protocol. So we have to get it approved by FDA, which is not going to be a problem because of those meetings I already said, but we have to get that, and then we'll have the ability for these teams to work with one patient under supervision, and then they'll be able to start treating patients on their own. So that's basically how, but we have 6,000 people, therapists, who've signed up on our website to be notified for when our training program starts. And we think that the maximum number that we can have in the residential, sort of the in-person, is 60. So it's going to be a long time. So that's our key limitation now, is how do we scale up the training program to get more therapists trained? And so they can only come from people that have actually worked with MDMA with PTSD patients. So we're looking at all of the phase 2 therapists and then the phase 3 therapists, and out of them we'll grow more trainers. So we're in the process now of trying to train more trainers, and it'll also be exponential. It'll start slow, but then we'll get more and more. So I think that there could eventually be, 10 or 20,000 psychedelic therapists or more. Yeah.
So, hi, I'm Marita. I work at MAPS. You can, at the back table in the back, too, we have some additional information about the requirements for the therapy training and the requirements for expanded access. We'll also be hosting a webinar on Wednesday, November 7th, called How to Become a Legal MDMA Therapist. It's $25 for the webinar, or $125 for the series of 7. So definitely more information will be available there, and it's from the people who are managing the therapy training program.
Great.
At this point, do you have any ballpark figure as to how much a dose of MDMA will
We're
cost?
talking about $150 for a dose, something like that. And there would be, 2 or 3 sessions, something like that.
I was afraid we were going to be talking about thousands of dollars or something.
No. See, the problem is, well, let me just say this. So back in 1985, I had a kilogram of MDMA made by Dave Nichols at Purdue, and it was $4,000 for a kilogram. Actually, he got 1.5 kilograms yield, and that's the MDMA we're still using today. So 33 years later, this MDMA is an extremely stable molecule, and it's just almost exactly as pure as it was before. However, getting medical grade MDMA, which is not any purer, but getting it in the final dosage form, first off making it, and secondly putting into capsules, is well over $50,000, $50,000 to $100,000 a kilogram, at least initially, because there's all sorts of stability studies, analytical method validation. So we're thinking it's going to cost us somewhere in the neighborhood of $50, $60 for a dose, which is outrageous because, underground chemists right now, you can get it for a few bucks. And it's not necessarily any better what we're going to have, but it's going to be legal and done in certain ways. So, no, we're talking about, let me just say one very quick thing, which is that under the influence of ketamine, I had I had an experience of watching Hitler give a speech. And it was very scary. And I was trying to just say, how do we think about Hitler? How do we try to do therapy on him? You know, and I saw him giving a speech to like 100,000 people in like the Nuremberg rallies, and I saw the way in which all these people with the Heil Hitler salute, sort of he would push it out, and then all of them would do it back, and it'd be like from the many to the one, and it would be this ping pong ball kind of ever escalating energy. But what I realized under this experience was that there was people have to be willing. There's no way that I could, that anybody could really change Hitler if he didn't want to. But what about all these people that are giving away their power? And so I think that what comes from what's that is that we have to really affect millions of people. Mass mental health. You can never stop the lunatics that will want to kill. So what that means is a low price. All of it gets back around to that, is that we're about maximizing mass public mental health, not profit. So that's how we'll do it. Yeah.
Yes. I saw a list that you had up earlier about. Can you hear me?
Yeah, I just couldn't see you.
Okay.
Yeah.
Yeah, you had a list up of potential expanded access sites in Europe.
Yeah. Well, those are phase 3 sites. Yeah.
So what is this list based on? Like, do they already exist, or?
Well, these are therapists from those sites have come to our training. So what we've done is similar to the FDA, where we had the special protocol assessment process, where you negotiate the protocol design. So we've done that with the European Medicines Agency, and we've come to agreement there. But the difference there is that in the US, you negotiate with FDA, and then you can do the study in any state. You don't have to have a special review, except for Reese's dad. California is the only place that you have another review body. But in Europe, you have to get approval by the European Medicines Agency for the design, but you also then have to get approval by each individual country. So we are now in the process of negotiating with the different countries, but we have teams that we're already training from those sites. That's what that, and those are not expanded access sites, those will be phase 3 sites. Expanded access sites will be those and more as well. And it'll probably take us till the end of, middle to end of 2019 to figure out exactly where we're gonna be able to go forward in Europe.
I'm curious about environmental considerations, and as the synthesis of MDMA is increasing, what that looks like ecologically.
Yeah, that's a great question. I wondered about that myself. And so I went to the company that was making the MDMA for us, and I said, where do you get this? And are you destroying all sorts of plants and stuff? And they said, we get it from petroleum. So it has nothing to do with plants at all. They take petroleum, they make all sorts of organic molecules out of it. It all starts with oil, basically. So there's going to be no negative other than getting the oil. Yeah, it's not like with ayahuasca. There is concerns about where the plants that make ayahuasca. The same is true with ibogaine, with the iboga root. That only grows, but with MDMA, there's not going to be any of that. But that's a really good concern. Yeah. Yeah.
Rick, what do you think about these statewide ballot initiatives that are coming forward? Any thoughts on those?
Yeah. So my first thought about these statewide ballot initiatives, the legalized psilocybin, is I wish they would just put the money into research, because the ballot initiatives are not going to pass. And really, what we're trying to say here is that the science has been blocked for 50 years by politics. And we want to get the politics out of it so we can do the science. Going to say in a state initiative, let's do by political means and not do the science, I think because it was so blocked with marijuana, I'm sympathetic with state medical marijuana initiatives, but now we're not blocked with psilocybin. We're not blocked with MDMA. And so I just had a meeting last week, actually, with the woman who's in charge of the Drug Policy Alliance, Maria. And so what she said is that if you look at the polling for psilocybin medicalization, legalization initiatives, or you look at decriminalization of all drugs, there's more support for decriminalization of all drugs. So that the initiative should be about decrim for all drugs, rather than making an exception, I think, for psilocybin. So I'm generally not sympathetic. If people want to spend their money on that, that's okay. I'm not against it. I think the drug war, these drugs should not be prohibited. So I'm not theoretically, but I think strategically it doesn't make sense. And I would much rather they say, yeah, we've got a chance to really embed in our society this as a medicine with insurance coverage through doing the research. I'd rather they put the money that way.
Thanks.
Yeah. Any more questions?
What was that name? Doran Darlin? Thank you so much. This is astonishing and wonderful, and who would thunk it?
Yeah.